Today, I would like to share with you one clinical case. In this clinical case, as soon as I present for you this clinical case, that's the question that I will ask you. What would you do in your daily practice in order to manage this clinical case without IDR? And after that, I would explain how to manage this clinical case using IDR. So this is the clinical case. This patient had a big problem in the upper left central incisor, this one. And I have to say that we have the balance between the gingival margin. This is really good. The papilla is in a very nice position. But if you see this CBCT scan, you will realize that the patient lost completely the buccal wall from the crestal bone to the nasal bone. So we have to restore not only the buccal wall that the patient had lost, but the bone that this patient lost above the apical part of this condemned tooth. And have a look when we sound this case, and you see here the periodontal pocket, and we have 5, 10, 15 millimeters in length. So just a confirmation that the buccal wall was gone, and the remaining bone above the apex of this condemned tooth was lost as well. So I can treat this case for sure as a compromised socket. Please, Arturo.
Quick question. So before we get into a more elaborate part of the case, a few questions from somebody that has not seen the patient, right? So question number 1, is that tooth moving?
This tooth?
Yes, is the tooth moving?
Yes. This tooth, this patient, let me tell one more information about this case. This patient had an accident, and this tooth came out, and she tried to reinsert this tooth. She tried to save this tooth, but she did not succeed. And she was suffering with pain and mobility, extra mobility, because we didn't have the presence of the buccal wall anymore. So we have 2 issues to be managed. The quality of the soft tissue was quite thin. We have the presence of the huge infection, and we also have the total loss of the buccal bone wall. So how to manage a very challenging clinical case like this in your daily practice? That's the main question to discuss with you today.
So I'll tell you what I know a few doctors would say. I'll tell you what I would do, and then we'll open mic for someone else who wants to share.
Excellent.
I know that a few doctors would say that if the tooth does not have a 2-dimensional mobility in 2 different directions, then the tooth should not be removed, and an apicectomy should be performed, and just keep the tooth there as it is, to address the mobility aspect and the infection. Since I'm an implantologist, I don't agree with that approach, but I know thousands of doctors would make that choice or that preference.
Arturo, we would go into this direction if we have the presence of the buccal wall and we have the infection and the bone loss only at the apical part of this condemned tooth. We would go in this direction, but we have to consider that this patient lost not only the buccal wall, but also the remaining bone at the apex. So this tooth is completely indicated to be extracted. So we cannot save this tooth anymore. So now the question is, how can we manage this clinical case?
So I'll share with you how I have done it before I learned about IDR with you. And the way I used to do it was an open flap, big flap. You have to extract the tooth. You will have a big bone fenestration. It's going to be a big wide opening. there's a lot of granulation tissue usually there. So you need to scrape out, clean up, disinfect. I would use ultrasound to clean up the bone to make sure it's perfectly nice and clean. I would place the implant, and with the open flap, I would see how the implant threads would be exposed. Then I would use, I know you're already smiling, I would use granulated allograft, a bone graft, and then I would use a membrane to protect and fixate that bone graft. Then I would, reposition the flap, a very sophisticated suture to keep everything in place, not easy. Many implant cases fail at the very end in the suture, but that's how I would do it. That's how I have done it until 2019 when I met you. Since 2019 and forward, I would do the IDR. But I used to do it that way. But what do you think?
If you go what the literature has recommended to us for such a long time, we would go into this direction. We would extract this tooth. This is what the literature, most of the articles and the authors in the literature has recommended to us for such a long time. We would do the tooth extraction to wait for between 4 and 8 weeks. After that, to do the second surgery. Maybe we can use most of the literature would recommend to us to perform a guided bone regeneration in combination with membranes, and we will close the flap again, second surgery, and we would wait for, this is what they recommend, to wait between 6 to 9 months to do the third surgery. What's the third surgery? Implant placement, and maybe in the third surgery, we would add some more extra bone in order to improve the thickness, or maybe the thickness and height for vertical and horizontal augmentation. Sometimes it's necessary. And we would wait maybe for more 4 to 6 months to do the fourth surgery. Fourth surgery means we would, in the fourth surgery, we would perform the implants uncovering. But for sure, one of these steps, one of this stage, we would add some connective tissue graft, extra graft, in order to improve now the gingival margin architecture position, to give back the outline of gingival margin and the papillae in its original position. That's what the literature would recommend to us without IDR. And maybe most of the clinicians around the world would go into this direction. But if we go into this direction, probably we will expect some unpredictability of the outcomes. What do you mean, Jose Carlos, when you say unpredictable of the outcomes? Because we are talking about the excellence in aesthetic. What does it mean, excellence in aesthetic? Is to give back the outline and the papillae position in its original position, or to improve all of this if it's necessary. So, but this is the outcomes that the patients are not looking for anymore, because they need to solve everything in maybe in one, or at the most in two surgical procedures. If we go to IDR procedure, you will manage everything in one single shot, one single surgery without open flap. This is make difference for your daily practice. I'm sure that will make the difference. This is what I'm feeling in all the courses that I've been giving worldwide. This is what the feelings that I may have for the participants, because all of them usually say to me, the IDR changed completely the way to manage compromised sockets. Will make my life easier, and for sure the life of this patient much more predictable, because you can offer a better treatment for your patients without open any flap. One surgery only, less morbidity and better outcome. This is all the patients are looking for, and outcomes like this.
One of the things that has happened to me after I met you is that I started to remember multiple cases that I wish I had known about IDR and I was properly trained on it to, how can I say this? It became more easy for me to identify past cases and new cases now that I have the IDR concept in my head. Now that I know about IDR, my eye goes directly to say, okay, this is a perfect case for it. I recently posted a couple of cases that have caused somewhat of more than 2,000 comments in social media. But I feel bad about the fact that before 2019, I did not have that know-how. And I wanted to take the opportunity today that's pretty much what you and I want for our fellow colleagues. Yes, this is an enormous benefit for the patient in so many ways, but also to the clinician, because you have to dedicate less time and less appointments to actually be empowered to offer a success treatment plan to your patient. And honestly, I did not have that until I met you. So now I pretty much look at everything, and I want to fix everything with IDR. And it's just something that is happening to me. I'm sure that there's like a before COVID and after COVID. I think clinicians can honestly say that there's a before IDR and after IDR once they learn the entire complex content behind IDR technique.
Yes. This is what I believe in. This is my mission, to spread the technique as much as I can worldwide in order to offer for your patient the best treatment ever in the management of compromised socket. Have a look at this case. After the tooth was extracted, we confirmed that the facial wall was gone. But not only from the crestal bone to the apex, but above the apex of this condemned tooth. So how can we manage that without IDR technique? And have a look how thin the soft tissue is. It makes difference. It makes a lot of difference. You realize that the gingival thickness in this case was barely 0.5 millimeters in thickness. So we have to pay attention that in the management of compromised sockets.